Good afternoon, everyone. On behalf of the Education and Professional Development Committee and ACCP, my name is Kelly Bach, and I would like to welcome you all to today's webinar entitled The Role of Antithrombotic Therapy, Post-Transcatheter Aortic Valve Replacement TAVRs. Is less more. We're thrilled to have Dr. Caitlin Kulig as our speaker. To introduce Caitlin, Caitlin is a clinical assistant professor at the Ernest Mario School of Pharmacy, Rutgers University, and the clinical cardiology pharmacist at St. John's University Medical Center. She spent most of her time at St. Joseph's on the inpatient side with the cardiothoracic surgery team, but does see patients once a week at St. Joseph's Cardiology Outpatient Clinic. Dr. Kulig received her Bachelor of Science from Stephen Institute of Technology in Holenburg, New Jersey, and her Doctor of Pharmacy degree from the University of North Carolina at Chapel Hill in Chapel Hill, North Carolina. She then went on to pursue a PGY1 acute care pharmacy practice residency and PGY2 cardiology residency at the University of California, Davis Medical Center in Sacramento, California. Dr. Kulig's clinical interests include mechanical support, anticoagulation, and advanced heart failure. In her free time, Dr. Kulig enjoys spending time with her two rescue dogs, Luna and Ashley. So I would like to now welcome Dr. Caitlin Kulig.
Hey, good morning, or rather good afternoon now. I'd like to thank everyone for joining me today on this topic that I happen to find very interesting. Like she said, we're going to talk about antithrombotic therapy today after transcatheter aortic valve replacement, and really answering this question, is less more. Before I continue, I have no conflicts of interest to disclose today. And really for our objectives today, I want you all to be able to describe really what is that risk of ischemic events versus bleeding in our patients that undergo transcatheter aortic valve replacement, also known as TAVR, to really be able to assess what the current guideline recommendations are for those patients post-TAVR. We're going to look at a lot of literature today, and I want you to be able to evaluate the most recent trials, investigating what really is the optimal antithrombotic regimen for these patients. And then ultimately, really the end game, right, is to analyze a given patient and formulate, an opinion as far as what would be the optimal antithrombotic regimen for that patient based on the most recent literature we will be reviewing today. This is a list of common abbreviations that I will be using throughout this presentation, so feel free to reference these at any time. But really, let's get started. So the real thing that we're going to be talking about today is ultimately boiling down to valvular disease. So as you all probably know, our heart has multiple valves located within it. And the purpose of these valves is really to prevent the backflow of blood and to ensure forward flow. Although sometimes forgotten about, these valves are really like a very, very important part of our heart and ensuring that we get ultimate blood flow through the left ventricle. So unfortunately, like everything else, we can have problems with our heart, specifically our heart valves. So on the left is an example of what a healthy aortic valve looks like. So as you can see, it's very pliable. It's able to open up quite wide to get that blood going off from the left ventricle, and it has a nice tight seal. On the right is what we're going to be talking about today. So our patients with aortic stenosis. So stenosis, of course, basically means a narrowing. So for some reason or another, oftentimes in our older patients, these valves become calcified and stiffened. And so they're no longer able to have this nice open valve. They get very tight and blood flow can't really pass through them. And so what you end up with is the aortic valve, right, is located between the left ventricle and the aorta. And so with aortic stenosis, your body, your left ventricle, is having a really hard time pumping the blood that's needed through your aorta. I kind of like to think of it like, drinking through a normal straw versus a cocktail straw, right? So the smaller the area is, like a cocktail straw, the more hard or the harder it is to really suck that blood out or push that blood out. So unfortunately, the clinical implications of valvular disease is that this left ventricle, which is already the workhorse of the heart, has to work harder and harder to push this blood out of the ventricle, right? In order to still meet the demands of the body. So what we see, unfortunately, in patients with aortic stenosis over time is that they develop thickening of the ventricular chambers. So I always say your heart's a muscle, right? Just like any other muscle. So if I went to the gym, unfortunately I don't, but if I did, I'd get really nice big muscles, right? Heart's the same way. So the harder your left ventricle has to work, the more hypertrophic it becomes. And then these patients end up with heart failure. So for the longest period of time, the only real option for these patients that had severe aortic stenosis was to undergo open heart surgery. So that means they had to go into the OR, get a sternotomy, right? Get their chest opened up, get put on cardiopulmonary bypass. So, as you can see from this picture, definitely not, an operation that doesn't come with a lot of risks. So unfortunately, we see aortic stenosis a lot in our older patients because they develop these calcifications over time. And like I said, this was pretty much their only option. So that was until this really ingenious physician came along, Dr. Henning Ruud Andersen. And when he was only a fellow and studying for cardiology as an academic fellow, he came up with this idea when he was learning about coronary stenting. And he kind of thought, hey, if we can stent open the coronary arteries, why can't we, in a way, stent open these stenotic aortic valves and basically implant a stent through a catheter method? So unfortunately at the time, right, he was only a fellow, and a lot of societies, organizations didn't really take him too seriously, and he was met with a lot of opposition. But he continued to really work hard to see his idea being brought to life. And so this is a picture that I think is so interesting. This is one of his first in pig implantations of his TAVR device. And then this is such a cool story, and a story I always like to share with my students as well. So here is Dr. Henning Ruud Andersen today. And after a lifetime of work developing this TAVR procedure, his father in the background ended up being too high risk to go an open heart surgery for his stenotic aortic valve. And so his father actually got the TAVR implanted. So he essentially saved his father's life with his life's work, which I think is just amazing. So, I'm a very visual learner, so I just wanted to show everyone, a visual picture of what we're talking about today, if you're not familiar with it. So again, the TAVR device, we're really implanting this valve via catheter. And so the catheter goes in, it goes into that position where the old aortic stenotic valve is, the balloon that gets inflated. And as it's getting inflated, this new prosthetic valve is put in its place. So it basically pushes that old stenotic aortic valve out of the way. And now you're left with a new aortic valve that's, prosthetic, and all with just a catheter directed method, no more open heart surgeries. So unfortunately, when we implant these valves, just like with our standard valve implantation, we're going to have a lot of different things happening in that area, right? We're going to have some disruption of that endothelial wall within the aortic valve area. It's also, right, it's a prosthetic valve, so you're going to have your extrinsic and intrinsic coagulation pathways kind of triggered. And so ultimately, even though we're putting in these valves, you have to really worry about now this activation of both platelets and your coagulation factors, ultimately then forming a thrombus. So the real question with these patients, even from day one, is how do we optimize these patients as far as their antithrombotic regimen? And how are we going to really balance the risk of thrombosis with this new valve versus the risk of bleeding, right? So even though it's not an open heart procedure, this procedure still is associated with bleeding. So really that's the question, is how do we manage or mitigate these risks? What is the optimal strategy? So first I want us to look at the numbers of what we can kind of expect to see in these patients. So when we're talking about ischemic events like stroke, it's estimated that about 7% of patients experience one of these within their first year after getting a TAVR implanted. However, when we're looking at bleeding, it's definitely usually higher. It's about 16% of patients within their first year after TAVR. And then even some sources estimate that major bleeding can be up to 15% of these patients at 1 year. So even though I don't want to, downplay the risk of ischemic events, as we know, a stroke can be very devastating. Ultimately, we are seeing on average more bleeding in these patients than we are seeing ischemic events. So now let's talk about what we have been doing, right? So in general, I would say most institutions everywhere, the standard of care is dual antiplatelet therapy, specifically with aspirin and clopidogrel. After these TAVR procedures, for really 3 to 6 months, we'll do dual antiplatelet therapy. And then after which time we will drop that P2Y12 inhibitor and do aspirin monotherapy lifelong. And really, again, the idea behind using antithrombotic therapy is we want to prevent those device-related thromboembolic complications, right? So we have these prosthetic valves put in, everything is disrupted, and then we really have to let the body slowly endothelialize around that metallic frame and have that tissue growth. And it's really only after that tissue growth is kind of completed that the risk of thrombosis will go down by a lot. And so we know that most institutions are using dual antiplatelet therapy, but I think it's important to consider where is the evidence behind this, current practice. And so initially, I was pretty surprised to see that really early trials that evaluated TAVR just from the get-go used dual antiplatelet therapy with aspirin and Plavix for up to 6 months after the procedure. And really, most of this was just extrapolated from data from intracoronary stenting. So for the most part, in other words, we knew we did this with stenting, and we had good data on that. And really from the get-go, we just used dual antiplatelet therapy for most of these patients. So there wasn't actually really good data supporting this practice. When we're looking at some original trials, so there was a trial that, they saw some thrombocytopenia after TAVR implantation in patients that weren't on clopidogrel. And they thought, hey, this might be due to some platelet activation, maybe thrombus formation. However, TAVR was not the same as it is today during that time. So at that time, they were still having to put patients on extracorporeal bypass to hemodynamically support them intraprocedurally. And then, of course, there's always this idea via histological studies that this valve incorporation process really takes about 3 months. When we start seeing fibrin being replaced by smooth muscle cells and endothelial cells. So to summarize, what we really knew at the time is that for other indications, we knew that single antiplatelet therapy versus dual antiplatelet therapy generally had less bleeding. We didn't really know in our TAVR patients, but as a whole. And then what we also knew is that our current practice is actually not really too evidence-based. It's kind of what we had been doing from the get-go. So the question I really want us to think about today is less more? And when we're evaluating our TAVR patients and what the optimal antithrombotic regimen is for them, I really want everyone to think about these patients in 2 different silos. And really that's looking at, does this patient have another indication for anticoagulation? So patients that are coming in, past medical history of AFib, already on a DOAC or VKA, versus your run-of-the-mill patient that is not on anticoagulation for anything else. So when we're evaluating literature and these patients, I want you to silo these patients first into those 2 main buckets. So first, I want to kind of talk about those that don't have an indication for anticoagulation. So again, maybe a patient, some of our valvular disease patients tend to be quite healthy. So maybe just past medical history of, even just hypertension, diabetes, not on any anticoagulant prior to coming in. And so let's look at what data we have so far. So in 2011 was this first pilot study that really investigated this idea for the first time. And that idea being, dual antiplatelet therapy is kind of what we've just done from the get-go, right? But when we're talking about the aortic valve versus coronary stents, it could be like comparing apples to oranges, right? Because your coronary arteries are very tiny, pressures tend to be lower compared to, your aortic valve, which sees some of the highest pressures in the body. It's much, much wider than, a coronary artery. So potentially less risk of thrombosis, right? And so Usei was the first one to really ask this question. And it was a fairly small trial, 79 patients, but he looked at patients that got dual antiplatelet therapy like we do today. So clopidogrel for those first 3 months versus aspirin. And he really found that adding clopidogrel to aspirin did not reduce any major adverse cerebrovascular or cardiovascular events or mortality at both 30 days and 6 months. So although his trial was small, this was kind of the first data that we had to be hypothesis generating as far as, hey, maybe we don't need this short-term adjunctive use of clopidogrel. Maybe single antiplatelet therapy is enough. In 2014, we had the TAVI trial, slightly bigger, so 120 patients. Again, comparing dual antiplatelet therapy to aspirin monotherapy. And once again, they didn't really see any statistically significant differences between groups, except they found that patients on that P2Y12 inhibitor had somewhat of a significant increase in the rate of vascular complications. So moving along, then we had a trial, the ART trial, which had 222 patients, similar design, dual antiplatelet therapy versus aspirin monotherapy. And they found that single antiplatelet therapy tended to reduce the occurrence of major adverse events following TAVR. And they also found that it reduced the risk of major life-threatening events. And really importantly, in this trial, they found that there was no signal of increased risk for MI or stroke in these patients that were only on aspirin. And then finally, we come to 2019, and this is kind of where our guidelines, our current valvular disease guidelines leave us, which was this 2019 meta-analysis. So, 20,000 patients looking at all these different antithrombotic strategies after TAVR. And they found that, that single antiplatelet therapy had significantly lower rates of bleeding versus dual antiplatelet therapy. And they didn't, again, see any differences in the rate of stroke among all regimens. And so really from this 2019 trial, along with these other smaller studies, we come to our current guidelines that kind of suggest you can use both, but not with really too much of you should do this. So really our current guidelines say, you can consider aspirin monotherapy in some patients, or also dual antiplatelet therapy is reasonable. So that is where our guidelines kind of leave off as far as literature review. But since then, in 2020, we had this pretty important in the world of TAVR trial come out that looked at aspirin with or without clopidogrel after TAVR or TAVI. So this is known as the popular TAVI Cohort A trial. So let's look at it. So it's a randomized open label international controlled trial with far more patients, so 665. Looking at the treatment arms, again, pretty much what we would call standard of care. So that dual antiplatelet therapy with clopidogrel and aspirin, that's going to last for 3 months, followed by aspirin monotherapy, compared to just aspirin, right? So aspirin monotherapy indefinitely. When we're looking at our inclusion criteria, so again, we're in the no indication for oral anticoagulation bucket. And we're looking at patients that are scheduled to undergo TAVI. For exclusion criteria, nothing too squirrely in this trial. So, they wanted to exclude patients that really had a compelling indication for, dual antiplatelet therapy. So any patient that got a drug-eluting stent or a bare metal stent within 3 or 1 months respectively were excluded. So this trial looked at a follow-up of 12 months. The primary endpoint looked at all different types of bleeding and non-procedural related bleeding over that period of 12 months. We ended up having 2 secondary endpoints in this trial. The first I like to think of as a composite of both bleeding or thrombotic events. So they looked at composite from bleeding, stroke from any cause, MI, death from CV causes. And then our second secondary endpoint only looked at ischemic events. So they looked at composite of death from CV causes, ischemic stroke, and MI. So some things I just want to mention. So if a patient had a stroke during a trial, they were allowed in the aspirin group to switch to clopidogrel. They did, of course, allow if patients developed AFib post-TAVI, which we do see sometimes, they allowed the VKA or DOAC to replace aspirin. But looking at this trial, ultimately, the reason it was done is that their hypothesis would be that single antiplatelet therapy would be superior to dual antiplatelet therapy in terms of bleeding. And again, this is a larger trial, kind of trying to validate what we've seen before with these smaller trials. And then they were hoping that as far as your first secondary outcome, which looked at both bleeding and thromboembolic events, they were hoping that single antiplatelet therapy would at least be non-inferior. So with this trial, they tested first for non-inferiority, followed by superiority. So if they met non-inferiority, they would then test for superiority. So this was a modified intention to treat trial. Pretty straightforward though, as long as they were randomized and got their TAVR procedure done. And they did adjust for multiple testing. As far as adherence to clopidogrel, so we saw a pretty good adherence event of 90%. And then which was really nice to see, they did end up reporting out how many patients ended up on oral anticoag after developing AFib. So that was about 13% in the aspirin group, and then 9% or 10%, 9.6% in the dual antiplatelet group. All right, so let's kind of start looking at what they found. So here is a snapshot of the baseline characteristics of this trial. So I think something that's really nice to see is this is very representative of what I typically see in practice. So, typically our older patients aged, around 80, very, very representative. I also think that there's a nice representation of female sex in this trial. So almost half. About 65% of patients had a class 3 or 4 NYHA score, but in general, like I said, pretty representative, which I think was nice to see. So now let's get into our results of our outcomes. So when we're looking at our primary outcomes, so if I could remind you, that really looked at all bleeding and non-procedural related bleeding. They found that for all bleeding, aspirin was found to be superior to aspirin plus clopidogrel, so significantly less bleeding. And that also translated on to non-procedural related bleeding. So looking at 15.1% compared to about 25%. And when they separated out and looked at severe procedural bleeding, they saw none in the single antiplatelet group, and they saw 1.8% in the dual antiplatelet group. So that is really represented out here in this diagram. So just to orient you, we're looking at cumulative percentage of patients with bleeding. And as you can see right from the get-go, we have a nice separation of lower bleeding events with aspirin that kind of continues on throughout that year. Looking at our secondary outcomes, so again, to orient you, that first secondary outcome that's listed down there really looked at both bleeding and thromboembolic events. And our second secondary outcome really looked at just ischemic events alone. So looking at ischemic events plus bleeding, so up in this area, we did find that aspirin was non-inferior to the dual antiplatelet group. And so at that point, they tested for superiority. And it was really nice to see that not only was it non-inferior, but it met superiority as well. Looking at the ischemic events, or the second secondary outcome, it was really nice to see that single antiplatelet therapy with aspirin met non-inferiority. Although maybe not surprisingly, when they ran for superiority, it did not meet superiority. So in other words, we wouldn't expect to see less ischemic events with aspirin compared to aspirin plus clopidogrel. All right, so just representing this out here. So this was looking at both ischemic events and bleeding, comparing that dual antiplatelet group versus aspirin. And then this is a representation of that secondary endpoint, which looked at ischemic events. So again, this is the one that met non-inferiority, but didn't actually meet superiority for the aspirin group. Again, we're looking at cumulative percentage of patients with an event. So in conclusion, looking at the popular TAVI Cohort A trial, aspirin monotherapy had lower rates of all bleeding and non-procedural bleeding at 1 year without sacrificing that thromboembolic protection. And so looking at this trial, it's a fairly large randomized controlled trial compared to the data that we've had before. And really nice to see that that patient population really representative of what we've seen in practice. And I think what's really nice is they captured both bleeding and thromboembolic events, although it was only powered to detect bleeding. Some cons, so procedural bleeding in this trial was defined by BARC type 4, and which is not used for TAVR. So about 60% of non-procedural bleeding was actually access site bleeding, which I think most of us would consider procedural related bleeding for our TAVR patients. And then the only other thing in this trial that I want to mention is they did not look at subclinical CT valve thrombosis. So this is something that we're going to talk about a little later in the presentation, but some trials do look at subclinical valve thrombosis. So CT scan, actually looking at that valve, is there any micro thrombotic, events happening there? But this trial did not look at that. The only other thing I want to mention, and that I thought was very interesting to note in this trial, is when we're looking at ischemic events. Again, we didn't meet superiority, we met non-inferiority, but I think it's interesting to see that after about 225 days, so far after your 3-month period, we did kind of see aspirin monotherapy kind of tick up a little. Which I think is a little surprising to see. So just something I wanted to note. I don't think there's a lot to be made out from this right now, but I think it is interesting to kind of have noted and see if we ever see this again in practice or in other trials, more hypothesis generating. All right, so based on this new trial, when we're talking about, again, those that don't have an indication for anticoagulation, it's kind of looking like single antiplatelet therapy might be better to use than dual antiplatelet therapy. But what about using anticoagulation for these patients? So that is where the Galileo trial came in. So again, a 2020 trial after our guidelines have been published. And it looked at rivaroxaban after our TAVR replacements. So again, these are patients that do not have an existing indication for anticoagulation. It was a randomized, open-label, event-driven, multi-center trial of 1,600-ish patients. Looking at our treatment arms, so we had a rivaroxaban group, which looked at patients getting rivaroxaban 10 milligrams daily, plus aspirin 75 milligrams to 100 milligrams for the first 3 months. And then after that, they would drop the aspirin and be on rivaroxaban 10 milligrams daily alone. And that was compared to a more kind of standard of care group. So we're aspirin plus clopidogrel for 3 months, followed by aspirin monotherapy. A couple things I want to point out. You might have noticed this rivaroxaban dose is one of our lower dosage strengths. So it's really the dose that's approved for DVT prophylaxis. And I think really the idea behind this was they wanted to test this hypothesis of anticoagulation while still mitigating that risk of bleeding. So using that lower dose. So when looking at inclusion and exclusion criteria, again, nothing too concerning to note. So patients that were at least 18 years old or older were included and who had successful TAVR. And again, we're excluding those patients that have another indication for long-term anticoagulation or an absolute indication for dual antiplatelet therapy. So if patients did establish AFib during this trial, so the rivaroxaban group would end up getting rivaroxaban at a treatment dose for AFib, and our antiplatelet group would get vitamin K antagonist to replace clopidogrel with a targeted INR of 2 to 3. And really the hypothesis of this trial would be that rivaroxaban would be superior to the antiplatelet group. And just a little bit of history about this trial. So there was some data in the past, especially when we're looking at subclinical CT valve thrombosis, that anticoagulation may be better than antiplatelet therapy in terms of preventing that, again, subclinical valve thrombosis that we see on that newly implanted valve. And so that's really where the Galileo trial got this idea to, hey, let's investigate the true clinical outcomes of using anticoagulation in these patients. So it was an event-driven trial. So the investigators planned for a follow-up at 1, 3, and 6 months, and then every 6 months thereafter. The primary efficacy outcome they looked at of a composite of death from any cause or thromboembolic events. So they looked at stroke, MI, symptomatic valve thrombosis, systemic embolism, DVT, or PE. And then their primary safety endpoint was to look at bleeding, so major disabling or life-threatening bleeding. Looking at our baseline characteristics again here, really nice again to see a pretty representative patient population of what we see. Again, patients around 80 years old, nice female representation in this trial as well. Most patients with hypertension, most patients, or at least half with heart failure, etc. And before we continue on, I'll have you know that the Galileo trial was stopped early. The trial was terminated prematurely by the Data and Safety Monitoring Board because of safety concerns. So let's delve into what they found. So when we look at our safety outcomes here, as far as looking at our major bleeding or TIMI major or minor bleeding, ISTH major bleeding, or BARC type 2, 3, or 5 bleeding, we saw that rivaroxaban had a higher, statistically significantly higher rate of bleeding in all of these different categories. And so really the reason this trial was partially terminated was because, hey, rivaroxaban is causing a lot more bleeding in our patients compared to the standard of care, even at that lower dose. And so that's kind of represented out here. So again, seeing, much more bleeding. This is looking at cumulative risk of our patients versus our antiplatelet group. So I know when I was looking at this data, I said, okay, we know that there was more bleeding, but did we at least see some more efficacy with rivaroxaban? So this is looking at our efficacy outcomes here. Something really interesting to note. So when we're looking at our primary efficacy outcome as a whole, we saw that rivaroxaban did statistically significantly worse than our antiplatelet group. And that was really driven by the risk of death in our patients. So in our antiplatelet group, we had 4.6% of patients die, whereas in our rivaroxaban group, we had 7.7%. And that is visually represented out here. So again, looking at our primary efficacy outcome, cumulative risk, much higher with that rivaroxaban group. So unfortunately, we saw, worse safety, and also it's looking like worse efficacy as well. And that is really driven by this death from any cause. So again, pretty large difference between our antiplatelet group and our rivaroxaban group. So in conclusion, terminated early, but the Galileo trial really found that rivaroxaban use at 10 milligrams daily plus that aspirin, keep in mind, was found to be harmful in those without an indication for anticoagulation in both terms of bleeding and thromboembolic protection. And so this is really where we get our class 3 harm, which is actually contraindicated, right? So in patients with bioprosthetic TAVI, treatment with that low dose rivaroxaban plus aspirin is contraindicated in our patients that do not need oral anticoagulation. Okay, so we just talked about our patients who don't need anticoagulation. Now, what do we do for our patients that need anticoagulation? So again, patient comes in, history of AFib, very typical in our patients. What do we do for those patients? Do we just do triple therapy, keep on their anticoagulant and add their dual antiplatelet therapy? What do we do, right? And so if we're looking at coronary stenting, looking at what's done there, because they're kind of in a similar issue, right? So patient comes in with AFib, now they get their stent placed, need dual antiplatelet therapy for that. Do we do triple therapy? What do we do? So we have the Augustus trial and then also the WOISH trial. And based on that, these trials kind of support for stenting, you drop the aspirin and you keep the anticoagulant plus the P2Y12 inhibitor. Okay, so we know we do that for coronary stenting, but like we said, TAVR is very different even physiologically than coronary stenting. So what do we do for these patients? And so that popular TAVI trial that we had just talked about, the reason it was called Cohort A is because they were really awesome and also did a Cohort B. So in that Cohort B, they looked at patients that needed anticoagulation for another indication, and they looked at anticoagulation plus or minus clopidogrel after TAVR procedures. So looking at our popular TAVI Cohort B trial, randomized open label international controlled trial of about 300 patients, looking at treatment arms again, so you can either be on an OAC alone, they allowed for both a vitamin K antagonist or a DOAC, versus our OAC plus clopidogrel group. And again, allowed for both VKers or DOACs, but then they would add on that clopidogrel for the first 3 months. Looking at inclusion and exclusion criteria. So again, we're looking at patients that have an established indication for long-term oral anticoagulation. And we want to exclude those patients that have an absolute indication for dual antiplatelet therapy. Like again, our drug-eluting stent, bare metal stent. This was designed very similar to our Cohort A. So just like our Cohort A, we followed up for a total period of 12 months. And endpoints very similar. So a primary endpoint, we looked at bleeding, so that all bleeding and non-procedural related bleeding. And our 2 secondary outcomes, the first one, just like the Cohort A, we looked at bleeding plus ischemic events. So death from CV causes, non-procedural related bleeding, stroke from any cause, or myocardial infarction. And our second secondary endpoint, we looked at ischemic events alone. So composite of death from CV causes, ischemic stroke, or MI. Again, a modified intention to treat. So patients would be randomized and they had to undergo successful TAVR. And once again, this trial allowed for both non-inferiority testing. And then if it was found to be non-inferior, then we would test for superiority. Looking at our baseline characteristics. So on the left here is our oral anticoagulation alone group, and then this is our OAC plus clopidogrel group. Main things to take away from this. So again, in general, what we would see, so 80-year-old patients, good female sex representation, indication for oral anticoagulation, I think is a big one to look at for our baseline characteristics. So pretty much all patients had AFib. So really that was likely what was driving their need for oral anticoagulation. So looking at our results now, so looking at our primary outcome, looking at bleeding, we found that anticoagulation alone was found to be superior in terms of risk for bleeding versus the anticoag plus clopidogrel groups. So again, 21.7% versus 34.6%. They found that access site bleeding was one of the major sites of bleeding, so 44% in the anticoag alone group versus 50%. And as far as severe procedural bleeding, they saw 1 in the oral anticoagulation alone group, oral anticoagulation plus clopidogrel group, and they saw no severe procedural bleeding in the oral anticoagulation alone group. And so this is really our visual representation of our cumulative percentage of patients with bleeding. So as you can see, it's looking at our oral anticoagulant plus clopidogrel group, much higher cumulative risk than our oral anticoagulant alone group. Looking at our secondary endpoints now. So just to reorient you, our first secondary composite endpoint looked at ischemic events plus bleeding, really. Whereas our second one looked at ischemic events alone. And so in terms of our ischemic and bleeding events, they found that our anticoagulation alone group was non-inferior to our anticoagulation plus clopidogrel group. And it actually reached superiority after it meant non-inferiority. When we looked at our second secondary composite, we found that again, this is just ischemic events, we found that it reached non-inferiority. So in other terms, anticoag is no worse than anticoag plus clopidogrel, but it did not reach superiority. So again, this trial is also kind of hinting that maybe less is more in these patients, that maybe anticoagulation alone is better than anticoagulation plus clopidogrel. And then this is really just going through the different types of bleeding that patients were having. And as you can see, it was really driven by this major life-threatening or disable bleeding. We see about 9% in our OAC alone group versus almost 17% in our OAC plus clopidogrel group. And again, something I just want to show visually here. So this is our death from CV causes, our bleeding, stroke, or MI. So that first secondary composite endpoint, which reached superiority. And then secondly, looking more at our ischemic events, this is the one that the OAC alone did not reach superiority, but at least it reached non-inferiority. So in conclusion, looking at the popular TAVI Cohort B trial, we found that among patients with an indication for anticoagulation, oral anticoagulation alone was associated with a lower incidence of serious bleeding over a year versus adding on that clopidogrel, and it was non-inferior in terms of adverse ischemic outcomes. Again, it was a fairly large, for what we have, randomized controlled trial with a fairly representative patient population. And I think it was really nice to see that ischemic events were at least non-inferior. As far as some cons of this trial, so they did not report time and therapeutic range for the patients that ended up on a VKA. Something to know is that most patients were on anticoagulation due to AFib, which, as we know, is not always the highest thrombotic risk versus patients that have multiple DVTs or PEs. And something else that's really a con of this trial is that most of our patients were on a VKA. So, 3/4 of these patients were on a VKA. So only a quarter were on DOACs. And looking at the DOACs, it was mostly apixaban and rivaroxaban, which I think translates into what we see in practice. But again, a very small percentage of patients on DOACs than what we would expect. So that's most of the published literature right now, but what do we do? So this is the ATLANTIS trial. So this is, the results have been announced, but it has not yet been published. So ultimately, when I think about these trials or the ATLANTIS trial, I think of using apixaban. So there was 2 stratas in this trial. And really, I think the best way to look at it is with this graph. So essentially, they were testing apixaban 5 milligrams twice daily. They divided it out into whether patients had an indication for oral anticoagulation or not. If they had an indication for oral anticoagulation, they were comparing VKAs versus apixaban 5 twice daily. And if patients didn't have an indication for oral anticoagulation, they were looking at your more standard antiplatelet therapy. So they allowed for both dual antiplatelet therapy and single antiplatelet therapy versus that apixaban 5 milligrams twice daily. Of note, they did allow for the dose adjustment if 2 of the 3 criteria were met. So this trial had a follow-up of 12 months, and the primary endpoint looked at death, MI, stroke, systemic emboli, intracardiac or bioprosthetic thrombus, episode of DVT or PE, or major bleed. So we're looking at a composite endpoint of really both bleeding and ischemic events. Unlike the popular TAVI trial, this trial did look at our CT scans. So they did have patients go to CE and to see if they had any subclinical valve thrombosis, or if they saw any reduced leaflet motion, because that could also represent subclinical valve thrombus. Looking at our inclusion criteria, exclusion criteria, nothing too squirrely to report here. So patients that had successful TAVI excluded if they really wouldn't be good candidates for apixaban anyway, to be honest. So patients that had really poor renal function, mechanical valves, taking CYP3A4 inhibitors, pretty much things I think that we would expect. So now looking at our primary endpoint. So kind of disappointingly, I think, apixaban versus standard of care didn't reach superiority in any of our factors that we looked at. And when they took out valve thrombosis, again, looking at that primary endpoint, we didn't see any evidence that apixaban would be better than standard of care. Looking at our secondary endpoints here. So interesting to note that when we're looking at that bioprosthetic thrombosis, so that really that CT visible or those thrombosis visible by CT, we did see a lot less in the apixaban group versus our standard of care group. So 1% versus about 5%. And we did see less DVT or PE in the apixaban arm as well. However, although not statistically significant, we saw numerically high numbers or higher numbers in other things like stroke or TIA or MI or things like that. Looking at our safety analysis, so when we're looking at different types of bleeding, I think it was kind of interesting to note that apixaban did not meet superiority in terms of any of the bleeding outcomes they looked at versus our normal standard of care. So again, just to reorient you, our standard of care was either warfarin in our patients that needed anticoagulation or antiplatelet therapy. So I think especially with our warfarin group, it was a little surprising to see that apixaban really didn't have that signal. So post-hoc, they really separated these groups into whether they needed oral anticoagulation or whether they didn't have another indication for oral anticoagulation. And to be honest, there's nothing too notable in our patients that needed oral anticoagulation. So as a whole, apixaban didn't really reach superiority in any of the things that we looked at. But in our patients that didn't need oral anticoagulation, so again, in our patients that don't have AFib, don't have a recent DVT PE, very interestingly, we saw a higher risk of death and non-CV death in our apixaban group versus our standard of care, again, which would be our antiplatelet therapy. So we're talking about 2.6% versus 0.96, which was found to be statistically significant. And if you would remember, this also kind of translates into what we saw with our Galileo trial, which also suggested that higher risk of death in patients that didn't need oral anticoagulation, even when we use that rivaroxaban 10 milligram dose with aspirin. Of note, we did see a lot less valve thrombosis in those patients. Again, this is subclinical valve thrombosis seen on CT. And it was a pretty big difference. So only 1%-ish of patients in the apixaban group versus 6% in the standard of care group. However, even though from those original trials, we're kind of seeing less valve thrombosis, reduced leaflet motion in that anticoagulation group, that's appearing not to actually translate into our clinical outcomes as far as, death, stroke, all of those things. So really from this ATLANTIS trial, again, not technically published, but results have been announced. They found that honestly kind of disappointing results for apixaban, in my opinion. They found that apixaban after TAVR was not superior to standard of care globally and in each stratum, even though we did see that reduction in subclinical valve leaflet thrombosis. However, like I said, we didn't really see this reduction in valve thrombosis translate into our clinical outcomes. And again, we saw that the bleeding was not better with apixaban than of our current standard of care. And most importantly, similar to that Galileo trial, in those that didn't have an indication for an oral anticoagulant, we saw that the apixaban group was associated with higher non-CV mortality versus that antiplatelet group. So this is another trial, which actually the results of this trial, I think is something that I'm really interested in seeing. So it's the AVATAR trial. So if you remember, we have data that's looking at anticoagulation versus anticoagulation plus clopidogrel after TAVR. So that was our popular TAVI trial. But I think a lot of us are starting to see that, you don't really need that P2Y12 inhibitor for TAVR. It may be kind of overkill since we're seeing that single antiplatelet therapy is good enough. And so I think a lot of us wouldn't really opt to do anticoagulation plus P2Y12 inhibitors for most of our patients anyway. So I'm very excited to wait for the results of this trial. So they're currently recruiting, which is really looking at anticoag alone versus anticoagulation plus aspirin. So I think this is going to answer one of our questions that we're having in practice. And then lastly, this is another trial. Actually, the results of this trial, it's not yet published, but the results actually have been announced since I started making this presentation. So I don't actually go into it, but basically this trial was looking at edoxaban in patients that have AFib undergoing TAVR. And they did actually find that edoxaban was non-inferior to VKA for efficacy, but we actually saw more bleeding in our edoxaban group compared to our warfarin group. So again, kind of appearing to be another strike against the DOACs, specifically here now with edoxaban. So in summary, what we know now, again, dividing us up into our two buckets. So in patients that don't have an indication for oral anticoagulation, we saw that rivaroxaban 10 with aspirin is harmful, the Galileo trial. And now with this ATLANTIS trial, it's appearing that apixaban 5 twice daily is being harmful as well. Even though we're seeing less valve thrombosis subclinically with these patients, it's not really translating to clinical outcomes, right? We also know that single antiplatelet therapy, both with those smaller trials and now with that larger trial, the popular TAVI Cohort A trial, single antiplatelet therapy is causing less bleeding than dual antiplatelet therapy without really seeing that increase in thromboembolic events, so non-inferior in that aspect. So based on the current data, I do think that there is going to be a slow trend towards single antiplatelet therapy alone for most of our patients. And I look forward to hopefully the guidelines representing this in their next update. Now looking at our patients with an indication for oral anticoagulation. So most of the data still supports using vitamin K antagonists because that's what was, really done for the longest time with these patients. If you were in between a rock and a tough place, I think maybe you could consider apixaban from the ATLANTIS trial, but really the results of the ATLANTIS trial were somewhat disappointing because we didn't really see superiority for apixaban in terms of efficacy or bleeding. So I would be a little bit hesitant to recommend that, really, because we didn't test for non-inferiority. And really, from this envisaged TAVI AF trial, I would not recommend edoxaban because we actually saw statistically significant higher rates of bleeding with a similar amount of efficacy. And so we also know that anticoagulation alone in these patients causes less bleeding than anticoagulation plus clopidogrel without, again, seeing that increase in thromboembolic events. So that's kind of where we're sitting today based on all this data that's come out in the last year. For future directions, really 3 buckets. So as you probably noticed, all of these trials excluded patients with a recent coronary stenting. And I think we probably will not see that type of data, since we know definitively based on our in our other ACS trials that dual antiplatelet therapy is superior to single antiplatelet therapy in these patients. So I think that patients that don't have an indication for anticoag and recent coronary stenting, don't think that's going to be studied. I think it's going to likely stay dual antiplatelet therapy, since now you have that, now your TAVR kind of doesn't become the primary issue anymore. You need that coverage for that coronary stent. The thing I'm most interested in is on that right here. So in patients that need oral anticoagulation, we know that adding Plavix is worse, but what about just adding on that aspirin monotherapy, or rather adding that onto your OAC, right? Since we know single antiplatelet therapy is good enough in patients that don't need anticoagulation, and we know that maybe OACs can protect that subclinical valve thrombosis, very, very interested to see the results of that ongoing trial. And again, in patients that have a need for anticoagulation and they had a recent stenting, again, I really think that the TAVR becomes less of an issue. And I think we're really going to continue doing our oral anticoagulant plus a P2Y12 inhibitor from those, Augustus and Willows trials. So I think your TAVR kind of becomes lower down on the list in terms of the need for antithrombotic therapy. I'd like to thank everyone for their time today. It's been really fun. It's a topic I'm really passionate about, and I hope you learned something new today.
Thank you, Caitlin, for the great presentation. If anybody has questions, feel free to put them in the question and answer session. And then I guess to get the ball rolling, Caitlin, is there any good resources or reference where you for pharmacists that maybe don't work with TAVR patients often, where would you go in the literature? Is there good guidelines, or where would you recommend for people to go if they, whatever reason, appear up post-TAVR?
Yeah, so the guidelines are kind of lagging a little bit behind. The most current guidelines are the ACCP guidelines for valvular disease. But again, they don't incorporate all this new literature. The ESC, or European Society of Cardiology, also put out, a recent guideline. But really, most of the guidelines are still going to say dual antiplatelet therapy or single antiplatelet therapy, and not really give a lot of good guidance for our anticoag patients.
Thank you very much. I don't see any questions in the thing, but if anybody does, you can feel free. For the sake of time, I want to thank very much Dr. Kulig for today's presentation, the CE code